Thank you. And thank you for the pronunciation of my last name. And for letting me present our data. I will hereby refer to pelvic organ prolapse as POP and stress urinary incontinence as SUI. And I have nothing to disclose. In welfare states, nearly 1 out of 5 women undergo surgery for POP and/or SUI during their lifetime. In Sweden, nearly 9,000 women undergo surgery for these kind of conditions yearly. Our aim was to explore the rate of surgery in relation to parity and mode of delivery. And a secondary aim was to explore cure rates and satisfaction among nulliparous women, women exclusively delivered with cesarean section, and women with a history of at least 1 vaginal delivery 1 year post-operatively. And this was a prospective register-based study in which we included women of 45 years of age or older from the Swedish National Quality Register of Gynecological Surgery, hereby referred to as UNOP. And the nearly 62,000 women which we included, they had surgery for POP and/or SUI between the years 2010 and 2016. UNOP is a nationwide register which covers more than 98% of all gynecological surgery in Sweden, and it assesses the pre-operative workup, including a 47-item questionnaire regarding, for example, parity, mode of delivery, symptoms of SUI and POP. The 1-year follow-up questionnaire also includes questions about symptoms of SUI and POP, but also asks about satisfaction with the result of the surgery. And the surgeon makes an assessment of both the pre- and post-operative information. And in this study, we define symptoms of POP as a feeling of a vaginal bulge once a week or more often. And UI was defined as leakage once a week or more often. And the self-reported data on parity retrieved from UNOP was checked against Statistics Sweden's total population register, which has basically full coverage. And the reference group was constituted by women of 45 years of age or older, and they were approximately 2.2 million. 3 subsets of women were described and analyzed in this study: nulliparous women, women with a history of at least 1 vaginal delivery, and women exclusively delivered with cesarean section. As for the results, mean parity in the UNOP population was 2.4 compared to 2.0 in the reference group. And this shows the distribution within UNOP. And as you can see, 97% had a history of at least 1 vaginal delivery, whereas 2% were nulliparous. 1% were delivered exclusively by cesarean section. And this shows the distribution of parity in the total population with no regard to mode of childbirth. And this is the reference group from the total population register. Almost 13% of Swedish women were nulliparous when 45 years of age or older. And the yellow bars shows the distribution of parity in UNOP. Compared with the reference group, nulliparous women were underrepresented by a factor of 7 in UNOP, and the multiparous women were generally overrepresented. And as for distribution of mode of delivery, nulliparous women were underrepresented by a factor of 17 compared to the reference group. And these shows the results from the 1-year follow-up. As for women who had SUI surgery, although the difference was small, nulliparous women were not as satisfied with the result of the surgery, and they did not experience cure as often as parous women. And for the women who had POP surgery, no significant results could be found. So we conclude that surgery for POP or SUI was almost exclusively performed on women with a history of at least one vaginal birth. And we could also see that nulliparous women in this data set had surgery for pelvic floor disorders 3 times more often than women who were exclusively delivered by cesarean section. So in practice, 97% of the demand for surgery for genital prolapse and stress and urinary incontinence can be attributed to a history of vaginal delivery. Thank you for your attention.
Thank you for that very clear presentation and that nice summary. When you get a number like 97%, it makes you sit up and take notice. I think that that's consistent with people's clinical experience. So what do you recommend as the way forward? Is this just what it will be? Should we make changes to not operate on nulliparous patients as much? What changes do you recommend based on the data and your findings?
I think we need to look into if the nulliparous group is different. Do they have more traumatic injuries? Are they suffering from more chronic obstipation? Or could there be any other factors that makes them still come to surgery for this? And maybe they need to be informed that they might not get the same result with the surgery.
Yes, I think most experienced clinicians would recognize that they are different somehow. And what those differences are, I think, is a fruitful area for further research. Are there other comments or questions from the audience? Let me follow up with just one other question. Based on your findings today, what's your next most important research question?
I would like to connect this data to another register in Sweden to look into more socio-demographic differences in Sweden, perhaps, and to see what happens with immigrants who come to Sweden. Do they get the same? Are they over or underrepresented in this material? There's so much to answer to that question. Yeah.
So you'll be busy for a long time. This is excellent. Any other questions or comments? Yes, at the top. Please identify yourself.
Lindsay Hanna from Manchester, UK. My comment is about, with this excellent study showing that delivery of children is a cause for pelvic organ prolapse. A lot of us as gynecologists and probably obstetricians are crying that there is a high rate of cesarean section. Don't you think that it is time for us to respect the desire of women who ask for a cesarean section rather than enforce them to have a delivery, which we know that it will double their risk every 10 years for having a pelvic organ prolapse surgery?
Oh yes, I think it's time. And I think at least maybe we could give them the same information, at least over our nation in Sweden, that we have, so they get the full information for what can be the side effects of the delivery mode for the rest of my life. Because I agree that I think that we focus on the nearest effects of the immediate effects of childbirth. So I think it's super important. And I also believe that the patient group needs to be the active part to convince the obstetricians to include this also in the antenatal counseling.
It's related, if I could make a related comment, that we don't really have, many places don't actually have an informed consent process for natural vaginal delivery because it's considered natural as the default. So most people don't undergo informed consent. They may sign some paper that gets pushed in front of them, but there's not the kind of consent process that would happen before an elective surgery, for example. Is that true in Sweden also? That
Yeah, and I can only speak for Borås, Södersborgs hospital where I work, and as far as I know, none of the obstetricians do inform women about pelvic floor disorders later in life. It's not just a part. It's not a part of it, and maybe it's also connected to that in Sweden the women don't have a free choice of mode of delivery. So maybe they don't find it necessary to inform the patients since it's not really up to them in the end.
I think, one of the things which probably we need to take into consideration is educating our midwives. Especially a lot of women, they book under midwifery-led care. And the midwife are always pushing ladies to have vaginal delivery and telling them it is a natural thing. But they never talk about pelvic organ prolapse in future. And I think we need to concentrate mainly on educating midwives, because where I work, I see a lot of women, when they say, I want to have an elective cesarean section, the midwife will go, trying to convince her otherwise that this is not the right way. You'll have complications with hemorrhage, you'll have complications. Everything in life have got complications. Crossing the road has got the risk of being run over by a bus. So we can't stay, we're going to stop doing that. But I think if we educate the midwives properly about giving the woman the choice, knowing the fact that the risk of pelvic organ prolapse multiplied by twice every 10 years in their life, and we are having people living now longer and longer, I think it is time for us to raise our hand and say, yes, we do agree with women to have elective cesarean section if they need it.
Thank you for your comments. We have time for the remaining 2 questions. Karen?
Concerning the nulliparous women, have you looked into patient expectations? Because maybe it's because nulliparous women, when they have surgery for incontinence, they have much higher expectations. They expect that they can do almost everything afterwards, whereas a parous woman perhaps only wishes to get somewhat better.
Yeah, yeah, that would be interesting. And it would have been awesome if this questionnaire also included a validated score so we could score them and see the severity of incontinence and see if that differs between the groups. But unfortunately, it doesn't in this questionnaire.
Thank you. And the last question?
I'm Dr. Xia from Taiwan. I have a question about your conclusion about nulliparous women have higher rate of pelvic surgery than women with cesarean section. It is difficult to imagine. Do you have performed a multivariate analysis to avoid a bias, or just univariate comparison? Do you adjust the age or other variable?
I'm so sorry, I did not quite get
I
your...
think that's a very important analytic point, and I wonder if the 2 of you could speak right after this session and work through how she did the logistics.
Yes.
That would be
sure.
helpful, okay?
Absolutely.
Thank you very much. We appreciate your presentation. Thank you.
Thank you very much.
Nobody knew what he was saying.